Thank you, sir. Good afternoon, Professor Kaul, Dr. Punamya, Dr. Rajesh. Can I share my screen now?
Yes, sir, you may.
Is it visible?
You have to start the slideshow.
Dr. Vijay Kumar,
yes, I've
has he
already
joined us? Vijay Kumar Subban?
Yes.
Okay. Vijay, we are not seeing you.
Can you see my slides?
Yes.
No, not yet.
Yeah. Slide is seen. I can see.
Okay.
All right. Good afternoon, everybody. In fact, I've been given a topic where I have to talk that you are damned if you do and damned if you don't. So, in fact, it comes from a quotation, life is a paradox. So, if you want me to choose one, anyway, I'm damned in some way. So, here I have to talk basically on assessment of borderline LMCA, angiography versus IVUS versus OCT versus FFR. What do I do? Do I just stick to an angiogram or do I proceed ahead for further investigations? What is borderline LMCA? 50% is a borderline LMCA. You see this diagram, what you see, it looks a very borderline LMCA. But what you see on an IVUS, the luminal area is something significant. So this, what might look to you on an angio may not be what is on an IVUS. Now, this is the picture. You see an angio is always a C, but if you go to all these modalities of either anatomical evaluation or a physiological evaluation, we try to see more of it, and that gives us a much clearer picture about what we have to see. Now, this was a study in which they had seen an borderline left main coronary lesions and did a correlation intravascular ultrasound. And you see this 30% lesion, but you see IVUS wise, you see it's significant, and the FFR was also significant. And finally, what they suggested was that always in borderline lesions, one should think of further invasive studies like LMCA, IVUS, or FFR. Now, three questions that I'd like to be answered. Is angiogram sufficient? Do I do further anatomical evaluation with an IVUS or an OCT? And is a physiological assessment essential? And as Dr. Saraj Chandra had given me the topic, damned if you do, damned if you don't. That's the whole thing. So my first question is angiogram sufficient? Now, angiogram mainly, when most up to 89% of atherosclerosis may not get detected also sometimes. There's a poor correlation with IVUS. Diffuse disease, we cannot detect. If there's a short shaft, we are unable. For example, in this case of LMC, where you can hardly see anything, opacification coronary sinus takes place, osteoangulation causes problem, bifurcation of the distal LMCA when complex angio and interluminal defect sometimes all causes problem and difficult to interpret. So IVUS may overcome all these angiographic limitations. Now, imaging is like this. What you see is basically looks like rabbit. But when you start doing imaging, you will see something which is more in a basket of fruits. So definitely imaging provides more than just a shadow of information what is provided by an angio. Now, the time has come for a change, so we should go. And I should answer my second question, that is further to an anatomical evaluation, let's take IVUS. Now, I stand in between that whether I should do or I should not do, but I'll definitely go ahead and prove why I should go beyond an angio. Now, let us see if you have a borderline lesion, you have either to take resort to either an imaging or to an FFR. Now, this is something that's very interesting. You see the proximal LMCA looks good, the distal LMCA you can see, 75% is also disease. So it is not that although the left main looks quite insignificant, but if you take two pullbacks, you'll definitely see that we're dealing with a significant reason, and definitely this will come positive if you go for a physiological assessment. Now let us come to the Mayo Clinic experience, which this is an old study where they took angiographically normal and minimally diseased LMCA and took a value of 7.5 millimeter square, which one should achieve while doing an angioplasty or LMCA. Now, they saw that if it was more than 7.5, it was deferred. And those which were deferred, definitely, they saw that they did well. But if it was less than 7.5, they started revascularizing them. And in fact, the long-term looks where up to 7 years follow-up was done, it was good. And then they gave the area of this thing confluence should be at least around 9.6 millimeters square. Now then correlation between IVUS and FFR first started being done with Louisville University study where 55 patients were taken, and they gave a value of FFR of 0.75 with the IVUS MLA of 5.9. But in a LMCA, you should have a FFR of at least more than 0.8. Now, the LITRO study, which we are all aware of, clearly stated that if the MLA is more than 6 millimeters square in a left outcome patient, revascularization can be done. But definitely, compared to clinical outcome, you see if it is less than 6, the results are definitely bad. Now, this was another study in which the intravascular ultrasound detectors for FFR in intermediate left ventricle patients. 55 patients were taken, published by Kang, in which they saw that definitely FFR does predict the long-term outcome and about the plaque burden. And definitely, if it is more than 0.8, the sensitivity and specificity is very high. Now, when to differ? You have to differ actually if it is more than 6 meters square, that is differing, or the FFR is more than 8, you can start. These are in the intermediate lesions. Now, these are the different studies which have been done, and definitely this figure sounds much better. These are the latest studies in which they showed that if it is more than 7.5, almost it's a normal population, and you can leave these left vents without handling them. Now, the cutoff point that has been taken from various studies because there is a regional variation, there is variation from country to country. Most of the studies have been done in Western countries where there are some 600 can be taken up a cutoff. But one thing one should remember is that you treat the patient and not the numbers. Now, I come to the next question, that is a physiological assessment essential? There have various FFR studies which have been done in borderline LMCA. These are the various studies where definitely you'll see the last, which was in 2009, which is clearly shown that anything more than 0.8 on FFR should be let off and should not be attempted. Now, this intermediate FFR evaluation has been done that anything more than 0.8 had less of death on follow-up up to even up to 6 years or 7 years. And even the MACE was also less, the FFR was 0.8. Now, modern current asks the question first, that is FFR of left main coronary artery stenosis reliable? It is definitely difficult because sometimes it depends on how you engage your catheter. While doing an FFR, one has to be careful that the catheter should not be engaged directly into the left main, and it should be away from the left main, and you should be doing it. And definitely FFR does have certain limitations in left main, and one has to be very sure about what are the causes of a false negative FFR and a false positive FFR, where also patients may have a differential response to your adenosine. Now, comparing IVUS and FFR, both same methods, IVUS and universal definite cutoff does not exist. There is a narrow range around 6, and especially useful in case of LMCA PCI. FFR definite cutoff values there for 0.8, there's a gray zone of 0.8 to 0.85. No characteristic LM disease, especially bifurcation, because left main does not come alone. There is always either a LAD or SERC disease. Here, FFR does have full reliability, is not there in FFR. Now, if you go, there is probably more agreement between FFR and IVUS in assessing lesions. So far as the left main length is concerned, the large sizes, and as I told you, there are potential limitations of FFR, and most importantly, IVUS provides the anatomical information which is not possible with FFR. This was comparison between the LITRO study and the study by Hamillers, in which they could correlate that more than 0.8 of FFR you should differ, and more than 0.6 on IVUS you should differ. Now, these are certain cases where you see that these are very borderline lesions where it looks like an angio, but when you do FFR, it was significant. So these are lesions which you normally might miss, and we take multiple views, and we have to be very sure that we are not dealing with a significant LMCA. This is another case where you see that although everything looks normal, but you see the distal LMCA, there's a plaque, but when you do an FFR, you see it is 0.74 in the distal LMCA. You can see that the LAD and the SERC are totally clean here, and definitely the FFR is significant. Now, I come to the third aspect, that do I further do an anatomical evaluation? Then and OCT definitely has got some limitations because when you insert the catheter while doing OCT, you may miss the ostium. Characterization is good. Luminal area can be found, lesion length can be down, but ostial miss is a big issue. So we have to think that possibly OCT takes a little backstage while evaluating the LMCAs, especially the ostial lesions. Now, but most importantly, for example, this looks like a significant lesion with some haziness over here. But when you do an OCT, you can see there is a lot of thrombus load. So these are areas where OCT does help in left vein, and strategize your plan whether you need to stent them or just leave them to medical management. So now if I'm asked the question, if you have a borderline lesion, whether I do an angio, an IVUS, an OCT, and FFR, if I'm given one choice and someone's pushing me that damned if you do it, damned if you don't, definitely I'll tell that I'll go for it. Because if you see, try to compare what are the various modalities. You'll see that addition to angiogram, we have to take resort to some form of anatomical or physiological method, to a functional assessment, to a proper anatomical assessment, and finally decide whether this borderline LMCA does require any intervention or not. There's always like angio is this elderly man who is going at the back, and this is this lady who is imaging or FFR who lets us see better and treat better, because we should know that you only see, look for, you only look what you know. Thank you very much for the patient hearing. And I think I'm convinced by it is not angio alone. We should go a little bit beyond that in all borderline lesions and try to see that we are in the right path. Thank you.
Thank you. Sir, Dr. Kaul.
Yeah, thank you very much, Dr. Sahoo, for a very interesting and a very colorful presentation, full of nice slides. So I agree that there are situations in which you need to be absolutely objective, because what the eyes see from the angiogram are very often, baffle us. And if you're very keen to do it, you start seeing, yes, it's a very good case. If you don't want to do it, you go in a projection where it's not showing you, so bad, and you go into it. So one needs to get into there and see the absolute picture from within the artery and be sure about it. And in that left main, I think everybody would agree, especially the usual big left main. IVUS is clearly superior, because number one, OCT, you have to inject dye and part of it cuts out, and pictures don't come very well. Plus, when the artery is very big, then the OCT images have a problem. So, do you IVUS all your left mains?
No, sir, I would not IVUS all my left mains.
Yeah.
Definitely, I would try to see if there is a doubt on my angio, I'd go further.
Okay.
Because
right. And FFR you reserve for after doing an IVUS?
FFR definitely post-intervention I'd like to do to see whether it is well intervened. And one thing is that if it is a lone left main without any other lesion, here you have got a good role of FFR. But if there is a combined lesion of an LAD and SERC along with a left main, FFR may be fallacious at times. So one has to be careful which modality you have to choose, whether you have to choose a plain imaging modality or just a physiological modality.
Dr. Kaul, shall we go for questions at the end of the session, sir?
As you please.
Yeah.
Okay.
Yeah, I request you to